simpler than I thought. Dr. Singal grew up in Bowmanville, Ontario, and eventually moved to Timmins, where his father was a surgeon, and that's where he graduated from high school. He went on to receive his medical degree in 1990 from the University of Toronto. He did his postgraduate surgical training in Toronto, obtaining his board certification of urology with the Royal College of Physicians and Surgeons of Canada in 1995. A fellowship from the University of Western Ontario in minimally invasive surgery, shock wave lithotripsy, and kidney stone disease was completed in 1996. He joined the surgical staff at Toronto East General Hospital in 1996 and served as head of the Division of Urology from July 2001 until October 2012. Currently, Dr. Singal leads the surgical robotics program, jointly run with Toronto East General Hospital and Sunnybrook Health Science Center, and is an assistant professor in the Department of Surgery at the University of Toronto. He supervises the Clinical Endourology Fellowship Program at Toronto East General Hospital under the umbrella of the University of Toronto, and also teaches undergraduate and postgraduate medical trainees. He works on Cancer Care Ontario initiatives related to prostate cancer care, and is a member of the board of Toronto East General Hospital Foundation. He serves on the board of Dignitas International. He has his own website, and if you Google his name, you'll get to his website. He blogs there on PSA testing, how complacency threatens our healthcare system, on mental health and its relationship to physical health, and on baseball. So talk to Bill Horty about baseball. We thank him for taking time from his busy schedule, from his wife and his 3 kids. Well, only one is at home. The other 2 are away at university now, but still has one in grade 11 at home, his little girl, and joining us tonight. Please welcome Dr. Singal.
Thank you, Ed. I appreciate that. Can everybody hear me okay? Is that okay? So I thought I would walk around a little bit. Of course, the downside is I have to keep this on my ear. So let me know if if it doesn't work, and I can always change. So thank you very much, Ed, for inviting me. I didn't realize I was going to share in your 20th anniversary celebration as well, and as a bonus, I get a nice piece of cake at the end. So thank you for that. I really appreciate that. As Ed said, I've never been to Thunder Bay, and I think it was in January that he sent me an email before he went to Hawaii, saying, would you mind fixing this date in September? And like many things, it always seems like a good idea when you've got this nebulous sense of when it might be. And but I was attracted to the idea of coming up to Thunder Bay. I've never been here. I wasn't sure if I would have another reason to come anytime soon, and I have an affinity towards Northern Ontario, having graduated from high school, and it's far in relative terms, but certainly there's a feel in Timmins that's shares something with Thunder Bay. So thank you for that, and thank you all for coming tonight and inviting me. I thought I would. When I give these kinds of talks, I would prefer that we eventually let this morph into a question and answer session. So I'd like to leave enough time for everybody to, who has a question to ask. And I'm not sure how many have smartphones, but I was telling Ed I was very excited to try and run this on Twitter as well. So if anybody wants to, you could use that hashtag #TBayProstate, and certainly anybody watching on the web, and that's something I can then scroll through that even later today or tomorrow or even over the weekend, and I might be able to answer some of your questions that way. So just another platform that I thought we'd experiment with a little bit and try. So again, thank you very much for that. So, prostate cancer is always in the news. It's a common problem. It affects men in a very real and tangible way. And yet there remains, despite years of making progress, a lot of confusion as to how, what does it mean and how best to treat it. And it's in the media. This is just a little snapshot of something that I pulled out now a couple of years ago, but really a sentiment that I think holds true today. And it really stems from the fact that there's a little bit of a dichotomous nature to prostate cancer. It's, as your mayor said, it's a very common form of cancer, and basically the most common form. And it's a significant cause of cancer-related death, and anywhere, the current estimates are maybe 1 in 6 might be actually at risk of being diagnosed over the course of their lifetime. And that's the challenge, is trying to find these men and ultimately protect them and keep them from harm's way. And just looking at sort of where we've been, you can see, there we go, that's the pointer. So basically, there was a huge increase, particularly in the late 1980s, and that coincides with the advent of a test, of an enzyme that we were able to test for, called PSA. And then there was a decline basically after a certain period of time, because it would make sense that there was kind of a rush to diagnosis when men who otherwise never would have been detected in their life were picked up in the late 80s and early 1990s. And it's very common, and just a few graphs that would illustrate that would show that it remains a common cause, despite the fact that not all men need to be treated, and I will get into that in a bit. There's no doubt that it's a real cancer, right? It's something that will be a significant cause of cancer mortality in amongst all of us as over the course of our lives. We've certainly seen an increase in the trends in PSA, and probably some decrease in mortality over the course of the recent time, and that trend has continued as time has gone on. And again, presumably we think a function of earlier detection of the disease, and so that's a significant thing to know. When I was a medical student, the textbooks that we read, probably about a third, even less than that, were actually men who would have been diagnosed at a point when they were able to be treated. Most men were diagnosed with advanced disease. That's what I learned when I was in a medical student, and that's a fundamental shift. We rarely see that, or we don't see that nearly as often, and so we have made some big strides in terms of how we look for and detect this disease over time. The biggest risk factor is simply getting older. And as you get older and you look hard enough, your odds of developing prostate cancer increase, and that's an important thing to know. Again, in general, we've made some strides in cancer in general in Ontario. The one big outlier, and this is why we've made some big strides with prostate cancer, and we don't want to dismiss that or discount that. If you look at that line for prostate cancer, we should be proud of that. These are survival rates that have increased from the late 70s, the patients of my textbooks, to something much more modern. That's a significant improvement in absolute survival rates from the 1970s. And that's a better dilemma and a better problem to have than if you look at the second bar. You look at pancreatic cancer, we've made no progress in that over the course of the last probably 50 years, and that remains a highly lethal cancer. So again, just a snapshot that we are getting better at detecting and making strides and keeping people alive and keeping people well. Does everybody know what the PSA test is? Presumably everybody in this room has heard and has some sense of it. So this is probably the hallmark or the anchor, if you will, of testing in prostate cancer. And so it's important just to maybe take a second to go back and tell you what it is. It's a normal protein that our bodies make. It's produced by the prostate. Its actual physiological role is to liquefy semen, so it has a role in fertility. And what we measure when you go to the doctor and do a blood test is essentially the amount of this protein that leaks into the bloodstream. So that's what's being measured. And so that's how it can be potentially useful. So it can increase with simply infections, with enlarged prostates, and with cancer. And it makes sense that any process that disrupts that normal barrier in the prostate, that keeps that enzyme in the prostate, presumably more of it will leak out, and that's how we measure values clinically. You don't have to read this. I didn't put this up as anything other than to say this is actually the Prostate Cancer Canada statement around PSA screening, and I'll go over that in some more detail, but it illustrates, if you go on the website, it illustrates what the challenges right now are. We've gotten very, very good at looking for and finding the disease, and by doing that, we've uncovered a lot of men that maybe don't need to be treated. So it's an important thing to figure out what your risk factors are and have a proper conversation with your primary care provider as to what might work best for you in terms of being tested. The challenge for us as urologists is that conversation at the primary care level. There's an assumption that there's an understanding of what that conversation should be, and I think even at the physician level, there's often a lot of confusion as to how best to look for and how best to advise our patients. The American Urological Association, this actually generated a lot of interest last year. So these were new guidelines. These are evidence-based by thought leaders in the urological community around the world. And this was sort of a statement which I don't think actually works at a clinical level perfectly, but this is sort of what's out there now and widely promoted and understood. So the idea of avoiding screening under 40, there's no need to necessarily routinely screen up until the age of 54 unless you have a higher risk. And I'll speak to what some of those risks are. And then there is some sense that between age 55 and 69, there is possibly some benefit to screening. Now, they made a statement that there should be no routine screening after 70, and then maybe we should consider using a PSA test and looking for it maybe every 2 years. So some sentiment here that I think most of us agree with, but at an individual level, there's a lot that leaves to be desired. And again, partly this reflects, these statements came out from the fact that while we've gotten very good at improving mortality rates over the years, what happened with that spike in detection is that we also got very good at probably over-treating some men, and then the realization that there are potential quality of life impacts, potentially some complications that come from that make it difficult to necessarily fully justify treating. So this is sort of what's out there right now, and I think it sort of misses the mark. It's not where PCCN has gone. It's not where most of us, I think, practiced in 2014, and I'll go over that in a wee bit. I didn't put the Canadian PSA guidelines up as it relates to prostate cancer detection, but I wanted to take a step just to talk about PSA in general. As you know, the prostate also grows as you get older. That's a benign process. That's a process that can cause men to have just simply difficulties with urination. Are any of you familiar with drugs called Avodart or Proscar? Have you heard those drugs? And so the only thing I would stress with that is that, if you are having a PSA from a screening point of view, certainly these drugs, if you're also having symptoms related to an enlarged prostate, your family doctor might need to draw a PSA on that basis. And the reason being is that PSA will go up simply as your prostate gets bigger, just from a benign point of view. And the challenge for us when we see people clinically, and I would just stress, if any of you in this room is on Avodart or Proscar, or your doctor is having a conversation just to treat an enlarged prostate, it's very, very important that your PSA be done before initiating that treatment, because that will artificially or falsely decrease the level of your PSA. and then it makes subsequent interpretation a little bit more difficult. So that's just something I would like just to highlight a little bit if I can. You shouldn't actually be on those drugs unless your PSA is at least 1.5, a normal reading, but not a negligible reading. And oftentimes, to this day, we'll see a lot of men come into the office with a PSA of X, and they're on the Avodart, and I try and go back and flip through the chart to see what was it before that drug was started, because if you're on that drug, your real PSA should actually be roughly double that value. So that becomes very important in interpreting what your risk might be for prostate cancer. I might stop there just for 1 second. I might just invite any questions. Anybody have anything at all at this point they might want to ask about that? Yes, sir. So the question was, I'll just repeat it for everybody else. So if your PSA is low and you've been told you have an enlarged prostate, why doesn't it show up on the test, meaning the PSA? So the term enlarged prostate clinically is often thrown around fairly liberally. You know, it's sort of a judgment your doctor might make when he examines you in the office, or it might be equated with a man who comes in with a variety of urinary symptoms. So not all urinary symptoms would necessarily always be attributed just to an enlarged prostate. So if you have a low PSA, like a really low PSA, less than 1, it's actually rare that at a true biological level that your prostate is particularly large. It's not probably that large to begin with. The way you would actually measure your prostate, and it's not, and I wouldn't suggest it has to be done routinely at a clinical level, but it's by doing an ultrasound, particularly a transrectal ultrasound that would actually measure prostate size. But the term enlarged prostate and urinary symptoms have tended to be equated over the years, but there's a whole variety of reasons you can have urinary symptoms that have nothing to do with your prostate. One more question, then I'll move on. Yep. So the question was, alluded to what's going on in the press around whether PSA is actually a useful test, and so that I hope I'm going to answer that actually as we go along over the course of today. So, because this is really where the controversy arises, and around PSA testing, this is the dilemma. There's the term 1 in 7 is used as your estimate of getting prostate cancer in your lifetime. It is equally true if you actually look at a microscopic level, your prostate cancer risk is probably even higher. It's probably roughly a percentage based upon your age. So the reality of it is at a microscopic level, maybe 70 to 80% of 80-year-olds have prostate cancer. And clinically, wouldn't necessarily know about it and will pass on without necessarily having it ever be an issue. They once did a study on gunshot victims in Detroit, and they looked at so they obviously died prematurely, and they looked at their prostates, and they found on autopsy studies about 25 to 30% of men who were in their 30s had some evidence, when you actually had the ability to look at the entire prostate, had some evidence of prostate cancer. So that's the challenge, because clearly most of those men would not have been destined to die from prostate cancer. So that's the big dilemma when it comes to PSA screening and prostate cancer detection, is if that's what's going on in the background, and if we clinically detect 1 in 6, 1 in 7, and if a proportion of those cancers are what we call, or what I like to call, real disease, how do you put it all together? So that's the controversy, and I'll hopefully give you some direction as to how we might go forward. If you look at the 20-year outcomes of following people with prostate cancer and who were treated conservatively, the idea of watchful waiting or expectant therapy, it really breaks down by age. So this is 55 to 59. These are older men. And then, so that's looking at it by age. This is looking at it by the severity of the disease. And basically, without necessarily looking at the details, if you see the higher or the more aggressive the cancer and the earlier in life you detect it, the more likely that you are to die from prostate cancer. So there's a phrase called, or a term called Gleason score, which is a measure of how aggressive the cancer is. So the dark black, basically this line is any death. The black line is a death from prostate cancer. And so you can clearly see the black line becomes almost completely fills the screen down here. A young man with aggressive prostate cancer, you can't leave that man alone. He will die from prostate cancer, and so on and so forth. So, and so that gives you some sense. And these are the tools that we start to use clinically when we tell a man that he has prostate cancer, that we clinically use to say, well, this is why yours may behave this way, and you might want to have something done, versus maybe leaving somebody alone. So it's a function of your age and the extent of what you find on the biopsy. It's not a yes, you have cancer, no, you don't have cancer discussion that we have. There's information on a biopsy that will actually help drive that. So I would actually argue PSA is the best tumor marker that we have. I don't think there is a better one that's clinically available, and at least to my knowledge right now. A man with an increased PSA is twice as likely to have cancer than a woman necessarily with an abnormal mammogram. And if your PSA is particularly high, your odds of having prostate cancer go up considerably, even allowing for other causes for PSA elevation. So again, a very useful test, but this really speaks to where the controversy tends to lie. While it is useful and the higher the value, the more likely it is you have prostate cancer. Probably about 20% of men diagnosed with significant prostate cancer have what we would historically have called a normal PSA, a PSA of less than 4. And many men who have cancers undergo biopsies. Biopsies are not without side effects. And probably the biggest challenge is the last line. The very fact that oftentimes when you label somebody as having prostate cancer, it kind of starts that whole treatment machinery, and that actually is a communication failure on our part as specialists, I think, and it's something that I think we've come to realize over the last decade and a half that we didn't particularly do very well. But that's hard work, because that actually takes real counseling, real time in the office, and spending time and understanding. So, somebody who might have minimal disease, making them understand why it's not necessarily appropriate to make an emotional decision to rush to treatment, and why your cancer might be followed. So that's really the dilemma, and it's less of an issue in Canada, where I think, for a variety of reasons, one of the beauties of having a resource finite healthcare system is that there's less incentive simply just to let the market drive the agenda. And so, because we can say, well, this person doesn't need to be treated and this person should be treated, but the hospitals are full and the operating rooms are always full, you can still practice best practice that way. In other markets, certainly in the U.S. market, there is a little bit more of a challenge when there is a little bit more of a drive to be treated because there's a competitive environment down there. I think PSA screening does work. It's, as I said, we find disease very early. When I was a medical student, most men were being found in their advanced stage. We have decreased prostate cancer mortality since the advent of PSA. And there's some things we can use to refine it, to hopefully tailor things at an individual level. There's been 2 main screening studies that have been done. They're not particularly helpful, I still think, but they guide us. There was one that was a U.S.-based study, which was this one, published a few years back in the New England Journal. Not a particularly good study. They compared 2 groups, screening to usual care, but there was a lot of contamination because the so-called control group, over 50% of them were actually getting routine PSA screening as well. So they showed no difference in terms of prostate cancer death, that there was no impact in that. Probably the more important study was the European study, which did show, if you followed men long enough, that you probably could see a true reduction in prostate cancer death. But they said you had to find a lot of men. And now that number, now that we're following people longer, is not 48 additional cases to find or to protect one man from dying from prostate cancer. That number is coming down the longer you follow patients. So really it's a function of the fact that it's a slow-growing disease, and some of our answers on screening are simply going to be borne out over time. So it is, again, it should guide you to the fact that it does, I think, make some impact. And this is just in table form comparing the screening trials. This idea of this number needed to treat. Statisticians, this pointer's not working very well here, but there we go. Statisticians love these numbers. Do you really want to treat 48 extra guys to save one person from dying from prostate cancer? It seems like a little bit silly to do that, but at an individual level, you could be that one person, and it can make a big difference. And as I said, as you follow these men and you go on a little bit further, that number I anticipate is going to significantly drop. And in fact, it is dropping quite a bit. Maybe 4 is not the right cutoff, and I've alluded to that as well. And it speaks to the fact that there are a number of men. So if you just took 1,000 men when you said, let me see what their PSA is, you might find 100 who have a PSA that's higher than 4, and 30% of them would have prostate cancer and 70% won't. But of those 1,000 men, 900 of them probably have a PSA that's low. But because 20% of people who have prostate cancer have a PSA of less than 4, that's potentially still a lot of men in an absolute number who you're not picking up with what we used to call your PSA as quote-unquote normal. If you look at most lab requisitions and lab reports, you still see this less than 4 as being kind of the reference range. So probably not a very effective way to do it. That number was actually picked out arbitrarily, 25 years ago as kind of, it just seemed like the right number. And we've come to realize that that's probably not the case. A couple of other tests may be worth going over. Has anybody ever had or asked about a PSA3 test in this room? No, again, it's a urine-based test. And the other one is PHI, or Prostate Health Index. And I'll maybe just touch on both of these. So the PCA3 is a urine test, and sometimes you're not sure whether you should do a biopsy. So it actually measures a little piece of this RNA, this messenger RNA, and comes up with a score based upon this urine test that your doctor will do in the office. And and then based upon that number, it will guide it'll guide whether a biopsy might need to be done or not. And a couple of issues with that. I think it does work, and I think it does have an additional clinical role it can play. The big challenge with this is it's costly. It's a $400 test out of pocket to most patients, although I think some insurance providers will cover it. I'm not sure. My own clinical sense is that it's had a significant role to really justify making men pay that kind of money. I don't particularly use it all that often in my own practice. This is new. This is, there's PSA comes in all sorts of forms, and so we're finding other sort of subforms or isoforms you can pick up. And this is actually a little bit of a mathematical manipulation, this PHI test, or the Prostate Health Index test. And so basically it's finding this pro-PSA, which tends to be associated with prostate cancer and higher, more aggressive forms of prostate cancer, and measuring its relative contribution to the total PSA in the bloodstream. And the FDA has actually approved this for PSAs that are in that sort of potentially that dilemma range between 4 and 10. And it does seem to have an improvement over PSA alone. It's not available in Canada yet. I've never used it clinically, but it's had a lot of excitement and interest in the U.S., particularly in the last year. I mean, I've sort of first heard about and so I've started seeing a lot of discussion over the last year. So a couple of simple lab tests that are available or soon to be available that you might want to keep in mind. So what is the way forward in terms of looking for the disease, managing our patients better, and basically at the end of the day, just trying to do right by our patients? And so I think we can make better decisions on whom to biopsy. I think we can definitely do that. We have a number of risk calculators that I'll touch on. we can probably identify meaningful disease better, and that's where finding better molecular markers and gene sequencing might help. And then the other thing that is evolving very rapidly is the role of MRI, and I'll touch on that a little bit as well. And then probably the other important piece is this idea of separating the paradigm of diagnosis from treatment. It's something that I think we practice now very much, and I'm very aware of it. As Ed said, I've written a little bit about it as well, in terms of doing this. And so prostate cancer screening and those recommendations I showed at the beginning from the American Urological Association will be fundamentally different if we actually adhere to this paradigm of separating diagnosis from treatment, because a lot of those recommendations are made in the context of over-treatment, that we are assuming there's going to be an over-treatment aspect to prostate cancer care. And then, of course, the fourth piece is, can we improve the treatment options? A lot of treatment options come with side effects or consequences, changes in urinary function, changes in sexual function. So how can we do that? How can we improve that? And that can be, maybe we look at surgery in a more center-based approach where it's done, by surgeons who have, who have a reasonably regular experience with doing the surgery, and that includes radiation as well. Does robotics have a role that's going to improve that? And then the idea of targeted, or what we call focal therapy. If you've got a disease and it's really one part of the gland and the rest of it is sort of irrelevant, maybe there's a way to deliver an energy source simply to that one area and save the rest of the gland from being treated, and then in theory lessen the side effects that come with that. So I might just kind of quickly go over each of these one by one. So I talked about risk calculators. So these are all available online, and I would encourage you to have a look at these. So this is one that I actually use in my office all the time. And I'll just maybe just go through it as a way to illustrate, how I kind of think about something. I usually, when I get a referral in my office, even if I haven't seen the patient or I'm just bringing them into the examining room, as I'm kind of leafing through what's been given to me, I can, in my mind, already get a pretty good sense before I've even talked to him whether I'm going to suggest that we do any biopsy testing or not. And, and I'll just maybe, it's based upon basically assigning points, recognizing that it's not just the PSA, it's evaluating family history, it's evaluating ethnicity, it's evaluating whether the prostate feels right on rectal exam. And just to put things in perspective, so this is your probability. So this is sort of your probability of having cancer. So the idea is each one of these things are points in a system. So let me just give you the example of a 60-year-old man. A 60-year-old man, that would buy you 35 points. He's black. That's another 20 points. He has a family history. That's another 10 points. So what's that? That's about 80 points so far. And his PSA is maybe 7. So that's another 20 points. And then we do this PSA ratio test, and his is on the unfavorable side. So that generates another 60 points. And I don't like the way his prostate feels. So you add up all of those by kind of going up there, and that means that, and then in that particular scenario, he's probably got about 160 points on that scale, right? So then I draw a line down from that, and I say, well, holy cow, he's got about a 60% chance of having cancer if I did his biopsy, and probably about a 35 to 40% chance of having what I would call real cancer, the kind I'd want to know about. So I may not go through this as a piece of paper in my office, but I make a mental calculation like this all the time when I see a patient. So you can actually do that on your own. That is basically the Sunnybrook calculator. So that's Rob Nam's mug there. He's one of my colleagues at Sunnybrook. So if you go on to Sunnybrook calculator outside Sunnybrook Hospital or Sunnybrook risk calculator, you can plug in your parameters that actually will is an electronic form of what I just showed on that first page. And this is another one. This is the University of Texas nomogram. So I use both of these, and this is also available electronically. And looks at most of the same thing. A couple of things it accounts for that makes it nicer than the other one. It accounts for whether you've actually had a prior biopsy. Because if you've had a prior biopsy and it was negative, then intuitively your risk might go down a little bit. And so oftentimes, if you're sitting in your office, in the office of your family doctor or your local urologist here in Thunder Bay, you might just want to kind of just run through these if you've been given some advice and you just want to get a sense of whether that makes sense or get a feel for how you might fall on the spectrum. So these are available. So that's something you can certainly look at. This is maybe a good practical way to go forward. It's been found that if I took 100 guys outside of the hotel here where I'm staying tonight and said, give me your PSA, let me just draw your blood, the overwhelming majority of men would actually have a PSA that's not low, but probably negligible, very, very low, less than 1. So that's where this concept of knowing your baseline or know your number, which has been a big thing that Prostate Cancer Canada has tried to promote over the last year, has come into play. And it's this idea that if you draw a single blood test in your 40s and it's really low, less than 0.6, your odds of having prostate cancer are probably significantly less looking ahead to the next 20 or 30 years than if your initial PSA is actually higher. And you can see if your PSA, if you draw a single PSA between age 44 and age 50, and if that PSA was above 1.25, your odds are much more significant. So I had a slightly different format, so I apologize that didn't show up very well on that screen with that particular template. But the idea being is that a family doctor would say, your PSA is 1.25, you're 44 years old, and he would be quite right to say it's normal, don't worry. But that might be the answer forward to how we screen for PSA, because I might argue to health policy advocates and how people who are looking to how do we pay for all this, I might argue that man at age 44 with a PSA of 1.5, which is normal, maybe that's the guy that we should follow every year or every, a little bit more closely. And if that guy, if the man at age 44, 45 has a PSA of 0.3 or 0.4, you could probably tell that man, don't show up again for 5 years if there's no other risk factors. So I think that might be a very practical way forward in 2014, to help counter some of this idea that PSA doesn't work. It's knowing how to make it work. And so I think this is a very important concept and speaks to this whole idea of establishing and knowing your baseline relatively early, by the age of, say, 40. And again, that's just a summary statement by Vickers that actually suggested that this is a way forward. So I think they're definitely on to something here, and I think this is something that we can do now, and I'm advocating this quite a bit. And again, just another way to illustrate what I've said. So maybe if you have a PSA that's less than 1, it's very reasonable, to do it again in 6 or 7 years. And maybe that's, governments don't pay for PSA, right? We all know this, unless you have a family history or there's any other so-called known risk factors. But those aren't good enough. Those risk factors aren't known. The majority of men, I had the humbling experience. I'm in my late 40s now, and 6 years ago, I had the humbling experience of operating on a man younger than me. So I was like in my early 40s then, and so you begin to realize that it does affect men, with younger, and the majority. It's been my experience in my 19 years in practice that while I know about all of these risk factors, the majority of men that I actually treat who we end up finding with clinically significant disease, if you actually ask them, they have no pre-existing risk factors. So there's something we're missing, right? To kind of glibly say you don't have a family history, we'll miss a lot of those men, and so we're not doing a good enough job. So I think this idea of a single baseline PSA early and looking for a number that's not normal or not just normal but negligible, I think is an important thing and an important and maybe an important way to at least guide us in the near future. The Melbourne consensus, Ed, I think I sent you the link on this anyways, and so it'll probably be posted on the PCCN site eventually. But this probably, in my mind, is the most sensible way to at least manage and think about prostate cancer detection at this point in time in the second decade of the 21st century. And this is a consensus. It was a prostate cancer conference in Australia last summer, in the summer of 2013, that basically came up with a number of statements that spoke to some of these concepts that I've just already gone through. And I would just summarize those 5 statements as follows, and I might just leave this up here for a couple of minutes. But, you know, this idea that we do know that if we look and we do PSA testing in men in their mid-50s and beyond, that we can probably reduce prostate cancer deaths. But the key statement, which I've already alluded to, is statement number 2. The idea that a prostate cancer diagnosis must be uncoupled from intervention. And if you can start to do that and think like that, then there's no harm in actually the PSA test alone. It's just a simple blood test. And, but that's a key piece. And that we should use PSA testing as part of a multivariable approach. And that speaks to some of those risk calculators that I just showed you earlier. Find out the family history, find out the ethnicity, what did the prostate feel like, what was the man's PSA at age 40, was it negligible or was it not? And also, you shouldn't dismiss somebody who's 70 or 72 simply because his birthday tells him he's 72, as we're not going to bother looking for this disease. If somebody is in good health and has a good expectation of living 10 plus years, they should not be denied PSA testing on the basis of age. If you go back to number 2 and you're prepared to separate diagnosis from treatment. And I have this conversation in my office all the time. You know, a man comes in and he might be even 75, 77, 78, and his PSA is 10. You know, and someone's done that now. You know, a lot of people would say, well, why do you do the PSA? Well, his PSA is 10. So then you have a conversation around whether you're going to do a biopsy or not. And I'm very explicit at the beginning that if I do a biopsy, there's a pretty good chance I'm going to find something just simply based upon your age. But that's not why we're doing the biopsy. We're going to do a biopsy to see whether you have, if we do it, whether you have that kind of aggressive cancer where, given that you're sitting in front of me and you're in pretty good health and you should probably live to be 88, 90, 92, whatever the case may be, that we, the two of us, me and that patient, can make a reasonable judgment that he will, that the disease will progress and intervene and impact on that life expectancy. So that's an important thing to know. I would argue that simply dismissing somebody as saying, he's 85, 88 years old, so what if he dies from prostate cancer? I think that that's a terrible way to look at the problem. I think dying from prostate cancer at any age needs to be avoided if we can. I mean, we're all going to die. But I think if that is something, I mean, it's incumbent upon us as urologists to try and protect men from dying from prostate cancer. And if you actually live to be 90 and you died in your sleep from a massive heart attack, then that's great. If you live to 90 but at 88, you truly had advancing prostate cancer, and that was what was the cause of death in the end, then, somewhere back along the way, at age 78, 77, somewhere along the line, an opportunity to maybe mitigate that risk was potentially lost. And so that's an important thing. Yes, sir. So when you're young, so in terms of your risk of having, the younger you are, by virtue of the fact that you're going to live longer, then a 50-year-old is going to live longer than a 70-year-old on average. So most of your risk is simply driven by age. So the idea of if your PSA is above 1 as a younger man, it's not that your risk at age 40 is higher. It's just this concept that your risk relative to a contemporary, a colleague who's the same age, whose PSA is 0.1, would be higher moving forward. So you should be watched a little bit more closely. I think that was the concept I was trying to ascertain. The corollary of that is probably equally important, which is that if you get to be age 60, age 65, and your PSA is less than 1, and I've started to tell people this, that your risk moving forward for developing prostate cancer is probably actually less than the general population. And I tend not to have those patients worry nearly as much, and I might follow them a little bit less aggressively. Does that make sense? Yeah, it's a little bit nuanced, and I'm happy to talk some more, and hopefully it'll flush out as time goes on. But it really speaks to the central dilemma. It's a very common disease, but it's different. It's different than pancreas cancer. It's different than lung cancer, where it's always about the earlier you find it, the better your odds are of surviving the cancer. Prostate cancer is funny. It's not like that. It's a lethal cancer. But it's a big paradigm, it's a big spectrum that goes from, never going to be troubled to, presumably, the kinds of cancer that Frank Zappa had, or potentially Jack Layton had, or somebody like that. So that's the challenge, is that we don't have perfect tools to always figure that piece out. And that's the hard part for patients to understand, because we'd be lucky. I showed you the pancreatic cancer stats earlier on in the talk. We'd be lucky to find men with pancreatic cancer early, but we rarely do. And we haven't done that, despite the fact that 50 years of better x-rays have happened. The majority of men who go for surgery for pancreatic cancer with curative intent, it's never done. It's never removed because it's too late. So that's the challenge. And because we got very good at finding it early, we then rushed to the market to then overtreat everybody, and we've saved a lot of men from dying from prostate cancer. But what's come with that, of course, is we've harmed a lot of men who, by changing the potential for quality of life. Thank you very much. I appreciate that. So that's the one concept. So we can, the Melbourne consensus is an important thing to know. And then there's this concept of active surveillance, which gets to what I've talked about, the sort of knowing where you fall on the spectrum. And it's a different concept from watchful waiting. So watchful waiting is we say, we're just not going to treat you. We're going to manage symptoms as they arise. If you have pain, if you have difficulties urinating, we will look after that. But there's no curative intent with that. The idea of active surveillance is that you have men who otherwise you might consider treating, and they're fit for treatment, but you make a judgment that their cancer is probably relatively low risk, and so you basically want to cure them if necessary, and then hopefully not harm them and overtreat them if necessary. So that's the concept behind surveillance. And the goal of any prostate cancer, of course, is this idea of the trifecta, that you want to control the cancer and make sure that our patient doesn't die from prostate cancer. But the other two things are important, right? You want to make sure that urinary function is preserved, and ideally sexual function is preserved. And I would say we actually don't do a good job. Well, we don't do the job we'd like to do, even to this day, in terms of achieving that so-called trifecta with all of our patients. So this is kind of what we want to do. So so then you have to make a judgment as to what are the relative merits. I mean, everybody wants to have the cancer treated if that's going to be a significant or serious problem. So Laurie Klotz, I'm sure Ed and others I certainly know the name. So this is one of my mentors. He's at Sunnybrook, and he probably is one of the thought leaders around the world on prostate cancer. And I've learned a lot from him over the years, and he probably single-handedly is responsible, or most responsible for this concept of promoting active surveillance. And he basically took a belief in this premise back in the mid-90s that we should look at this concept. And now it has sort of become standard of care for low-risk disease. So the idea that if you have low-risk disease, you might not need to operate or offer radiation to the majority of patients. And he put a few endpoints where intervention would be offered. If the PSA, DT refers to doubling time, your PSA changing rapidly over time, and if the Gleason score on a subsequent biopsy progressed to something more significant. And basically you can see that the majority of men actually don't die from prostate cancer. Even within that trial, the men that died mainly died from other things and not from prostate cancer. So the actual prostate cancer death in that group that had low-risk disease was actually very, very small. The problem, of course, is that about 30% of those men did end up undergoing intervention. And of course, if you have surgery, you have the ability to then effectively biopsy the whole gland. And then the dilemma or the problem, of course, is that, so RP refers to prostate cancer surgery or a radical prostatectomy. So about 50% of those men who actually did have intervention had a margin that was positive. So there's this disconnect, right? So most of those men aren't dying from the disease, but there's a small group that potentially had significant disease, and when they had intervention, we weren't perfectly still finding it when it was completely contained. So the thought from Lori was, and I think this is a reasonable thing to do, is that it should be offered. It should be part of the discussion for low-risk disease, and but of course of the 117 that were treated, a number of people did actually end up having a PSA that was progressive. So favorable risk disease, and certainly in men who might be over the age of 70, is the ideal patient who might want to be treated with this idea of active surveillance. So it begs the question, well, if that's a good idea, but there are a subgroup of men that aren't being picked up or being maybe falling through the cracks with active surveillance, how can we do better? And I think this is one area that is rapidly changing. I'm not an expert in being able to tell you the technical side of MRI, but certainly as a clinical user, I see this space rapidly changing over the course of the next few years. So MRI can be used in a number of ways. Could it be used as a screening tool? It could be. People are starting to ask for it, particularly in Toronto, where they have the ability to say, I'm just going to go and pay for it in Buffalo. For the so-called PSA dilemma, as I like to talk about, there might be men in this room, who've had sort of this PSA, your doctor's concerned, you go for a biopsy, it comes back negative. He says, come back in a year, it's higher still, you do another biopsy, it's still negative, and the PSA keeps going up. And so what do you do with those men, where you're kind of worried, but you haven't been able to kind of find the disease that matters? MRI can be used for active surveillance, potentially. Is there a role to refine those numbers I showed you earlier and intervene a little bit faster? And potentially to improve surgical outcomes as well in surgical treatment. So what is the value? So I think if you take a step back, this graph highlights the fact that biopsies themselves are not without risk. It's a test where you put a probe in the bum and you introduce a small needle and take some samples of tissue. We cover people with antibiotics to mitigate, to reduce the risk of infection. We are blessed that we all live in a world with antibiotics, but we've overused them. And so what's basically happened over the course of the last 20 to 25 years is our bacteria become much more resistant. So this graph, without knowing the details, but basically the upward line basically refers to hospitalization, the need to come into hospital within 30 days of having a biopsy. So this was Toronto, this was Ontario data, and it looked at from what the incidence was back in the mid-90s to what the incidence was in the mid-2000s. And basically the rough number we quote now, it's about 2 to 3% your chance of actually having a complication related to a biopsy that will require a visit to the hospital. Usually infection, usually related to an infection. So that's a significant, it's still a low number, but it's a significant number, and it's changed significantly. Even today, I did 11 biopsies myself on Tuesday, and I had to admit somebody last night with a post-biopsy infection. So It happens often enough. And so that, so we can't be cavalier around biopsy. So that's one thing to consider. We don't do these very much in Canada. This idea, well, maybe you should just bypass the rectum. Can you go through the perineum, which is the space behind the scrotum and before the anus, and could you introduce needles that way? You could. It's a little bit cumbersome to do. It would no longer be an office procedure, probably would require an anesthetic. I don't see this as a significant solution, at least in Canada. But you could probably get other parts of the gland that we sometimes miss by going from behind. And so the idea of MRI is that, again, you can look at it using different, you can manipulate it differently and come up with a series of images that will allow you to ascertain whether there's something that might be worrisome or not. And then you can, this is a machine that's at Sunnybrook, but actually even this is not always done. So the idea is if you see something on an MRI as a nodule, you could then map it back to the ultrasound that we use for the biopsy and in effect superimpose those images and then use that to target the needle in a more intelligent way and try and establish your diagnosis that way. And again, these are just a series of images that show, the far superior image of the MRI with the ultrasound and how you can superimpose these two and have a radiologist find what needs to be found. You can record where you did the biopsies a lot more accurately than you can with a simple ultrasound-based system. So PI-RADS is something, actually the breast cancer folks are way ahead of prostate cancer. They actually are probably 15 years ahead of what we do with prostate cancer in terms of understanding detection and how to improve things. So in breast cancer, for years they've used this term BI-RADS, and it basically refers to what you see on an X-ray and how suspicious it is. So with MRI, if you are in an office and you have an MRI of your prostate, it'll generate a report based upon different zones of your prostate, and it'll each of those zones will be given a score from 1 to 5. And that basically is what drives our assessment of how worrisome something looks. And that's actually the challenge as to why this technology is not easily disseminated everywhere yet. I mean, you have every community has MRIs, but it's a function of having a radiologist with enough expertise to reliably report things in a way that's reproducible and consistent. So this is really the scoring system that is now used for MRI. And so can you use it as a screening tool? Well, the answer is you can. I mean, there's no doubt if you had an MRI-guided biopsy, the number of cores you would need to do are less, the actual number of needles you would need to put in, and the number of despite the less cores, the number of more significant cancers you would find would be significantly higher. And you'd actually probably miss the low-risk cancers, which we wouldn't necessarily want to find anyways. And so that's the dilemma. So there's no doubt you can do it. The issue, of course, is cost. I mean, that's going to be a very expensive thing. To date, we're not suggesting that anybody show up as an MRI in place of a biopsy. People ask, certainly in Toronto, people do ask, as there is some awareness now that this is available. I do discourage it. We have to use our resources in a finite way, but perhaps there might be a role for this in the future as we refine our risk calculators a little bit better. Those calculators I showed you earlier with that point-based system, that I think is just the beginning. I think there's going to be, new measures that we can develop, new ways to calculate it. And maybe there'll be a role within that to say, well, you know what, if your point score is X, maybe that's the man that we suggest gets an MRI as up front. So stay tuned. I think that's something that over the course of a few years may be refined. We'll have some specific indications where that might be the case, but it's not a screening tool right now. I think for the PSA dilemma, that idea of the rising PSA, the negative biopsy, I think there's a role for MRI here. I use it in this scenario actually more and more It's again something I tend to see. So I talk about it. I talk about it as my spider sense. When my spider sense is not quite right, and I know there's a family history, and and I'm just worried about it, and I haven't been able to find that disease. It's got to be somewhere, and my needle just hasn't hit it. And it really speaks to this. This idea of the prostate evasive anterior tumor. So my colleagues at PMH coined this term. They use the term PEATS, what we call PEATS tumor. So a typical typical biopsy is done by placing a probe in the rectum. And so the needle that you introduce to take samples basically will sample very well the part of the prostate that sits up against the rectum. And that is truly where most of prostate cancers tend to be. But there is a whole area that we never biopsy, the so-called anterior tumor, the one that's furthest away from the rectum. And so if you look at this as an example, this is the rectum back here, this is the whole prostate. So this is what we call the peripheral zone, or the area that we would typically biopsy. But what if you've got a bad tumor way up here? You'd never see it. You'd never find it with a typical biopsy. And so those are the ones that I think might be picked up with an MRI a little bit better. And so so a lot of these men you might pick up with MRI, and I can show you. Again, I had one other slide that showed that. Maybe I'm sorry, I don't. But they actually did, that PMH group did actually biopsy and found that most of those patients actually, if you see something on MRI and it's a PI-RAD scale that's 4 or 5, if they do have cancer that's found on the MRI guided biopsy, it usually is actually the kind of cancer that you would want to have treated. And so so there's the role for that PSA dilemma. And then there's the role for MRI, I think, in active surveillance. And so we don't want to overtreat men, but we ideally don't want to miss the boat, right? You want to capture people and find the disease that needs to be treated earlier. Why put them on surveillance if you can identify more quickly or sooner that this is the man that's going to need to be treated? So the standard protocol for active surveillance, and some of you might have had a discussion with your doctors around this already. So a typical standard of care protocol right now is you do a biopsy, you tell a man for reasons X, Y, and Z, I'm not going to treat you. And typically you'll do PSA testing and you'll see if there's any rise, and then you'll do a follow-up biopsy at 1 year to see if there's any change in what we call the Gleason score. And if there isn't, then you'll maybe do another biopsy 3 to 5 years after that and carry on. So can MRI change that? And the answer is it probably can. And so this one again was a pilot study that was done at PMH, and it looked at basically a group of men who had the typical active surveillance type of parameters and who hadn't been treated and who were basically young enough that they were going to live for a period of time. So all of the guys that I would say were low risk disease. And they were basically then given MRIs, and they were put in 3 groups, whether there was something, whether they had a normal MRI and whether we picked something up. And it's interesting, if they actually saw something on MRI and they biopsied it, the number that were actually reclassified, meaning that they actually found a progression or the kind of cancer that you would actually want to treat, was very, very high. The men who were on surveillance where nothing was found on MRI, you carried on. And so there was actually a pretty good, a very good correlation between the two. If you have a negative MRI, it's about 95+% that the odds of only having something non-aggressive is in fact what exists. So again, something that I think can be done and treated very, potentially used very well. So I think MRI can definitely identify early disease, and also people who are going to be on surveillance but who actually might have something more significant. And basically, in that study, 20% of people who you otherwise might have just followed were actually then offered potentially a treatment. So it might actually be a much more sensible way to guide active surveillance. And not routinely, but I've started, probably in the last 18 months of my practice, certainly for younger men, where we put them where I've decided to put them on surveillance. I've started to ask for this, and it's changed practice for me in a number of situations where there was something found, and then we did a targeted biopsy of that spot, and then we intervened. And so I think it may be very good. And again, this was a more recent Sunnybrook study that looked at the same sort of thing. And so they actually looked at two things here. One is MRI actually had a much better way. This is a typical man who was on active surveillance where they found a nodule. But this is actually the graph that matters. So if there was no cancer seen on MRI, that was good. So these 4 columns go back to that PIRADS score I told you. So this is PIRADS 3, this is PIRADS 4, and this is PIRADS 5. And basically, MRIs were very good, 6-fold better at finding Gleason 6 disease if there was a nodule MRI, and about 3.5 times better of finding the more significant disease, a score of Gleason 7 or higher. And you can really see what happens here. So if you had a PIRADS 3, so these are surveillance patients. These are men that you otherwise would just follow. And they had a PIRADS 3. The number is 6%, that if you actually biopsy that nodule, that nodule would show Gleason 7, Gleason 8, or Gleason 9 disease. And if they had something more significant, a PIRADS 4 or a PIRADS 5, those are almost always significant, and you'd almost always want to intervene with those men. So again, a very impressive, I think, way of being able to look a little bit better and inform our decision-making a little bit better. And so I might just kind of stop there and just say in closing, because I really just want to open it up. I suspect there'd be some questions, maybe some confusion that this has generated, but it's definitely common. Prostate cancer, it's a disease that ranges from harmless to lethal. And I think establishing your own individual risk profile that goes beyond what's my ethnicity, what's my family history, I think is important. And I think you guys, your organization nationally is onto something with this idea of establishing your number, knowing your number, and knowing what that number is early, figuring out what your PSA is at age 40 or age 45. Find an HCP, a healthcare provider, with interest and understanding in the nuances of the disease. A lot of the guidelines glibly say, have a conversation with your doctor. The doctor has to know what he's talking about as well and understand, what all of this means. And so that's really an important thing to know. And then if you do have prostate cancer, then define your disease. Figure out whether you've got the kind of disease that needs to be treated. I like to call it finding the big fish. So, our approach to biopsies in prostate cancer is like an ocean trawler that goes fishing. And you'll pick up all sorts of stuff, and you'll throw out the small fish, but you're really hoping to find, the big ones, the keepers, if you will. And those are the ones we need to find and we need to treat, and we need to try and keep those men out of harm's way. And then this idea of separating diagnosis, this premise that diagnosis has to equal treatment. I insist, when I give the news to a patient, there's a very normal, very emotional reaction. Well, what are we going to do? What would you do, doc? And I make it a policy that, we're not going to have that conversation today. I'm going to give you a tool so you can go home, do a little homework, and understand where you fit in that spectrum and how you might want to then come back, and so we can have a more objective, somewhat less emotional conversation around that. And I'll actually add, and your mayor brought that up as well, that central to that whole conversation is our partners, our wives, and our sons and daughters in all of this, because it's almost impossible, I think, to go through this alone. And if you're lucky enough to have a partner in your life, I think that leads to better clinical decisions, and I think better outcomes in general. And also having the ability to have another set of ears listening when you're going over that decision making is very, very important. So I've been quite humbled, I think, by the impact that prostate cancer has had on men and on their families over the years, and it's something that I think everybody should be very proud of, and I think that's something we always need to acknowledge and address. So I might just stop there, and I look forward to seeing if anybody has actually called me on Twitter later tonight, but maybe it's just me having a conversation with myself. But I might just stop there and just invite anybody who might have any questions. So again, I thank you for inviting me tonight, and I hope that was of some use. And I'll maybe just I'll stop. You had your hand up.
Just a second. I want to mention to people who are watching this on your computer out in the region, if I think that there was a place that they could write questions, but I'm not sure if that's being monitored. So if you've tried that and haven't got a response, write down my number, 807.
He's brave.
628 6915. That's my cell phone. 807 628 6915. And if you have a question for Dr. Singal, please send me a text or give me a call so that you're included in this question and answer session.
Go ahead. I would have repeated your question, but that's good.
Difficult. And secondly, I'm wondering, I did hear something about the effect of radioactive dye on the kidneys when you do MRIs, and I'm just wondering if you could respond to those two questions.
Sure.
Thank you.
So the first question was around PSA, what's a normal PSA for an enlarged prostate, and the second had to do with MRI and the injection that one has and its effect on the kidneys. So with respect to the first, there's probably no absolute right number. I think, again, it's, clinically, if you have an enlarged prostate and, that number is in the range of 5 or 6, you could chalk it up to that. The way I would probably answer your question, though, is that, any number that starts to get above 4 traditionally, you have to make a clinical judgment that it's not something else. And then say, well, you can chalk it up to that. Certainly if you get above 10, I think there's pretty good evidence and pretty good sense that as your PSA gets north of 10, then you really have to be careful in saying that this is just due to an enlarged prostate and that there's a lot of overlap up until that. But the way I would use it is, hopefully with any luck, a patient who comes into my office would have had a baseline, and I have some sense of what his PSA might have been 5 years ago, 7 years. Has it changed very much? And then I'll use that to incorporate that. But, I certainly after 10, I would say get very concerned, and then be, individualize it before that. As far as X-rays and kidneys, it's that risk of toxicity is very, very low unless you have pre-existing kidney disease. So that's really the key piece there, and so that's measured by a blood test called creatinine and glomerular filtration rate, or GFR. And if those are normal, that should be fine. And at least never say never, but it's very, very low. So diabetics and hypertensives, hypertension patients, those are the two common medical conditions that lead to kidney disease as time goes on. So those two things, just as a just as an opportunity to kind of speak to that, are both things with your primary care physician that should always be controlled as optimally as possible to minimize the impact for things like kidney disease down the road. But otherwise, if you have good normal kidney function, that's remote.
I have two questions. One is the biopsy.
Yeah.
That, in my mind, is a very tiny surgery. My wife died of metastasized breast cancer, and she was, the surgery was done twice, and it was apparent that the first surgery missed the margins. They cut through tumors, and they couldn't tell afterward for sure, but that there's a fairly high chance that you release this in situ, like all biopsies before that had said it was in situ. Mm-hmm. And that when you cut through the margins, leaving some of the tumor intact, your risk of metastasis is much higher. Now, my question then, with biopsy, the core needle can pass through a very small in situ cancer. Mm-hmm. Are you increasing the risk of metastasizing that cancer? That's my first question. The second one was about the drugs to treat enlarged prostate. What are they? How do they work? What are the side effects? What can you tell us about the treatment of non-cancerous prostate enlargement and the symptoms like difficulty urinating and such?
Okay. So the first question had to do with the potential harm of a biopsy as it relates to manipulating the cancer and potentially causing spread. So there's no evidence that it makes any difference with prostate cancer. So I can answer that, I think, emphatically. I mean, biopsies have been done for a long, long time, and this idea of disrupting tissue wouldn't make any difference. And it probably speaks to the biology of the cancer being different from breast cancer to some extent. And, and in fact, there's a whole group of patients who actually have more than in situ prostate cancer, who actually have prostate cancer, who we don't treat anyways because they're not likely to intervene. So I think so the answer is no. There's no evidence that will make any difference or cause any risk of metastases. As far as the second question goes, so yeah, there's an enlarged prostate. If we're all lucky enough to grow old, that's something that will probably affect every man to some extent, and its usual manifestation is urinary symptoms, difficulties urinating, and a whole variety of things. So the question was, tell us about some of the drugs around that. So there's basically two sets of drugs, or two classes of drugs, and they'll go by the names commonly Flomax or Zatrol or Rapaflo is the new one. Those are a class of drugs that are called alpha blockers. They don't actually reduce the prostate size. We came to realize a number of years ago that there's probably this sort of muscle tone, if you will, within the prostate that kind of makes it tighter. And so these alpha blockers, which can basically block that or manipulate that to sort of relax where the prostate joins the bladder. And so they're great for symptomatic relief. And often the first thing we'll reach for when somebody comes into the office with symptoms to say, here, let's try some of this, because they usually work pretty quickly. The second class of drugs are called 5-alpha reductase inhibitors, and they go by the name Avodart and Proscar. And so those drugs basically manipulate 5-alpha reductase, which blocks the conversion of testosterone to a submolecule called dihydrotestosterone, which is what actively works in the cells to grow the prostate. And so the idea being, by blocking that enzyme and preventing that conversion, you can reduce and maybe reverse the effects of prostate enlargement over time. So they actually do work to potentially undermine or reverse the disease. So they're great drugs. A couple of points worth knowing. There is some controversy as to whether they can lead. There was a couple of trials that were done to see whether those drugs could actually protect people from prostate cancer. There was two big studies that were done, the prostate cancer prevention trial and the REDUCE trial, which each looked at each of those two drugs. And the idea was, let's put guys on these drugs and see if they have less risk of prostate cancer. And the answer was yes. And the risk was about 30% less, so pretty significant at first pass. And so both of them, Avodart and Proscar. And so for a while there was a lot of excitement. Well, we should put everybody on this. There's no better drug to actually reduce prostate cancer risk, or there's no better way to reduce one's prostate cancer risk. Let's just put them on this drug. So then when they did a sub-analysis, the thought was, yes, the reduction was 30%, but within the group that were diagnosed as having prostate cancer, it seemed that a higher proportion of men who were on the drugs had, the more aggressive kind, the more active kind of cancer. So the FDA actually released a warning about 3 years ago now that said that it shouldn't be used for what we call chemoprevention, to sort of prevent prostate cancer. The Canadian Urological Association takes a more nuanced view of that. My feeling is that it probably does have some impact on reducing prostate cancer. And did it cause a more aggressive cancer, or did it simply, by shrinking the prostate, make the bad actors a little bit easier to find? That part's not clear. Most of us probably, because there is enough noise and enough debate around this, won't automatically use it as a here, just take this because it's going to reduce your prostate cancer risk anymore. But I do use that drug still a fair bit in men who have coexisting symptoms related to an enlarged prostate. So if you've got a man with a bigger prostate who is troubled by how he's passing his water, who says, you know what, I also have a family history of prostate cancer, I think that's a very reasonable thing to consider, putting such a man on that to potentially reduce his risk of prostate cancer as well, as long as he's under my watchful eye and being closely followed. So an interesting group of drugs. Some of the side effects are related to decreased libido and minor complaints around sexual function, and very rarely or occasionally breast tenderness or breast swelling. Breast tenderness, enlargement, but less than 1%, very rare. But something I do mention to patients with that. Yes, sir. So the question was, how long should Avodart be taken? For you to actually see any benefit, you need to be probably on it a minimum 6 months to start to see any effect. So the idea of what's forever, there's no drug study, there's no big pharma will never fund a study that goes out 20 years. It's just not economically makes any sense. So the Avodart, the studies have looked, they're typically 3, 4, 5 years out. There's no evidence of any long-term ill effect of those drugs, and so they are designed. If if a patient has a nice response to a drug like Avodart, to stay on them, the way you would stay on an antihypertensive or your diabetic medication. As I see men and as they come back, year after year, I will ask them, after a few years, we'll reassess, do you still want to be on it? How much your symptoms have improved? Are you tired of taking a medication? And so I have some men that have been on it for a number of years, and some that'll say, you know what, thanks, but no thanks. But the minimum response time is 6 months. And then just to reinforce what I said during the talk, if you're going to go on those drugs, your PSA should always be done prior to that, because just as a rule of thumb, the drugs will drop the PSA by 50%. So a lot of patients get happy saying my PSA has dropped, and that's all well and good. But if your PSA was 4 before, and your PSA gets down and it's 3, and then it's 4 a year out, 2 years out, when I make an assessment in my office, a man whose PSA is 4 on Avodart really has a PSA of 8, right? So I actually would worry about a man like that because it's actually doubled where it should be. So if it hasn't gone down by 50% once you've started, or if it got to 50% and then starts to rise, we actually see that as a red flag, and we tend to. Pardon me? It's a camouflaging effect. That's exactly, that's a good way to think of it. Absolutely. Anything else? Yes, sir.
I
So the question was referred to his friend who was diagnosed with prostate cancer and is seemingly doing well, and had what he called seeds implants. So there's a variety of ways to treat prostate cancer. A variety of ways to treat cancers in general. You can either cut it out or you can try and kill it. How can you kill it? Well, you can heat it, you can cool it, these are all things you can do to try and destroy it. So seeds, but the main two broad ways to look at prostate cancer treatment are to either remove it through something called a radical prostatectomy, and that can be done a couple of ways. It can be done through a small, relatively small open incision, which is still the standard of care, and an emerging way to do it in a less invasive form using laparoscopic or robotic techniques. And so that's the one broad way. I'm a surgeon, that's what I tend to do. But a reasonable and equal choice, and it's again, a lot of this is driven by patient preference, and also the parameters of the disease are to offer radiation therapy. So radiation can be delivered a number of ways. It can be delivered in what you would think of as X-rays, a typical external beam therapy where it's from the outside. And then brachytherapy, which is the seeds that your friend had and what you talk about. And so the idea is that you can actually put in radioactive pellets into the gland, into the prostate, that will decay over time. And as they decay, they emit radiation. So the idea is you can deliver a much higher dose of radiation to the prostate that way than anything you could deliver externally. And so it's a great form of treatment. It's a treatment option generally for men who have low to what we would call low to intermediate risk prostate cancer. And again, people will make that choice for a variety of reasons. It's less invasive than surgery. It might have I think it has probably a better side effect profile. The downside to radiation in younger men might be, we don't know what the effects 20, 25, 30 years down the road might be. There are some long-term effects of radiation that, we're starting to appreciate some more. But for the right patient, if he made that choice, and when those were all offered to him at that time, that's what he would have had. Yes?
Two questions. One is, if the drugs that are used for BPH can suppress or camouflage PSA,
Yeah.
some people are taking herbal supplements to try and do the same thing. Do we know if they have the same effect?
Okay, and your second question?
The second question would be, if you go to a doctor and you get a PSA test and they say it's borderline, the first thing they're going to do is a DRE, visual exam. You didn't talk much about that and its role.
Okay.
And is it something you're still using a lot, or are you going more for doing ultrasound and stuff like this?
Okay. So the first question had to do with the, I forgot, the camouflage in the PSA. And with those drugs, right?
Yeah, but some people use herbal supplements.
Yes, that's right. So the idea is that there's a lot of men who are on things like saw palmetto and other, and so I'm not aware of any significant effect on PSA. They probably does have a weak effect on that enzyme I talked about on the 5-alpha reductase pathway, but I'm not aware of any significant impact. I would say a lot of men are on saw palmetto and swear by it, and I never discourage it. In fact, I encourage it because I think it provides a sense of control around for a patient to sort of also be involved and actively participate in his care. So I don't think it makes a significant difference to that. I should have answered your questions one at a time because I've already forgotten your second question. Yes, of course. Yeah, you know what? Forgive me if I didn't bring that up. So a digital rectal exam should always be done, and that's, the one nomogram I showed where I put all those points. One of the variables was a DRE. In fact, 2 points I'll make on that. One is there are a lot of family doctors, primary care physicians who will say, well, I did the PSA, I'm not going to do the rectal exam. That's a no-no. So everything you have to think of it as building a case, right? So you have a man in front of you in the office, And it isn't one thing, right? It's this plus this plus this plus this that's going to make me say, I'm worried about you. And that includes the rectal exam. So, and it really is important with a PSA that is quote unquote normal. The guy with a PSA of 1.5 or 2, and if he has an abnormal rectal exam, it almost trumps everything else in my mind. Now, if you looked at it statistically, how many rectal exams would you have to do to kind of miss, to miss the prostate cancer? Probably lots and lots and lots, but it's a core part of being a doctor in my mind. It's a physical exam. It doesn't cost anything. In the same way you're going to get your heart checked and your blood pressure checked, you should have your prostate checked. Prostate, and not just prostate, actually looking for rectal cancer, right? Because that's also something that can be done. So that's the important thing. And the only other thing I'll say with that, the other common mistake that happens in a primary care setting around PSA is there's a reflex, if the PSA is elevated, to automatically prescribe antibiotics. I'm not sure if anybody in this room has had that experience. Well, let's see if the antibiotics bring the PSA down. And that should be frowned upon. There's no evidence that makes any difference in terms of prostate cancer detection. And probably it creates a lot of harm because it speaks to some of that risk around prostate biopsy infections because we keep throwing antibiotics at a man. So when I see somebody who has a PSA of X and he was given antibiotics and the PSA stayed at X, and then I say you need a prostate biopsy, I always talk about biopsy infection risks. The one thing that predicts a higher risk of getting an infection and being hospitalized is exposure to antibiotics within 6 months of that biopsy. So not a good thing to do. So definitely something, a common practice pattern, and is something that we're really trying to educate and prevent people from having. Yes, sir.
I'm one of the people that had a biopsy, and then the doctor's spider sense said, I missed it, I want to do another biopsy.
Mm-hmm.
When you think of active surveillance and using biopsies to follow,
Yep.
What's the percentage of missing the cancer with a repeat biopsy?
So the Toronto active surveillance experience has been about 30% of people on surveillance eventually go on to needing something done. So you're right, the odds. So when you do the 1-year biopsy, before MRI, the men who on the following biopsy had a Gleason score of 7, so we would say you've progressed and you need something done. The truth is that I think probably the majority of those men had the Gleason 7 the year earlier that your biopsy just didn't pick up. And so if the repeat biopsy shows no progression and the PSA is steady, I think that risk is small. If the second biopsy 1 year apart doesn't show any progression, and you could probably safely tell most of those men to follow. But the MRI does, if you were to have an MRI, is it basically allows for that, if you did have something on MRI, then you would not, you might not wait a year, you would just target that one spot. And that's probably what we find. We're just what's the word? We're uncovering that a little bit faster. I may not quite have answered it exactly what you wanted though.
How often do they miss the cancer on a repeat?
On the repeat biopsy? Well, I think that risk is small, except for that so-called anterior tumor that we see. So, I still think overall that number is small, but at an individual level, if you actually have one of those anterior tumors that were missed, you'd want to know about it. But presumably you'd catch that. If there was something really nasty or really significant, you'd start to see a trend in the PSA. So, what often happens on that second biopsy, there's no progression, and then a patient, the patient says, okay, so I guess I'm good to go. So I usually tell them no. Even if nothing happens with your PSA, I will plan on another biopsy 2 to 3 years afterwards. And my practice is changing a little bit now that I have access to MR. But that's typically what I would do. So I think that risk is small, but it's quite small actually, and it's not zero. That one graph I showed about the patients on active surveillance who had a PIRADS 5, that's pretty good. If there's something on MRI and you biopsy it, that's usually something, if it's a sort of a significant thing on MRI, that usually is proven to be something significant. That same study showed, because all those men had MRIs and then had a regular biopsy. The guys, only 2 guys in that study who were on surveillance who had an MRI that was seemingly normal actually were found to have Gleason 7 disease the regular way. And so I think that risk is small. And so I think I'm personally a big fan. I hesitate to say it just to a community group because you don't want a run on the bank to having MRIs, right? It still has to be used sensibly, as particularly in our system here in Canada. But I think it's rapidly evolving. I think it will definitely inform our decision making and the advice we give men in that whole active surveillance space. And I think it's going to change that, I think, for the better as time goes on, for sure. And then certainly that second group, that TSA dilemma group as well. Yes, sir.
My question that came to mind is about family history. So your father, your brothers, and so on. Can prostate cancer risk vector through female ancestors?
Yeah.
Does your mother's father, your mother's brothers?
Yeah, absolutely. Maybe a little bit less, not quite as high, but definitely yes. So that family history works both ways for sure. And certainly if there's a cluster of cancers in a family, then it's worthwhile to get to have that evaluated as well.
A few years ago, I had an opportunity to listen to a presentation comparing radical to robotic laparoscopic surgery, and the numbers that he was quoting then put them pretty well both on equal basis, the results and side effects, etc. Have those numbers changed anymore? Is robotic laparoscopic, is it proving to be a lot better way to go?
So the question had to do with whether robotic surgery, what's the improvement over conventional surgery? So the way I would answer that is say the most important factor is the surgeon, full stop. So if you have a good surgeon who is experienced and is good at the operation, you will probably have a similar cancer outcome no matter what you choose. Now, I do think robotics is better, but let me explain where it is and where I think there's no difference. There's no doubt that I think recovery is faster. So I did 2 robotic patients on Tuesday, just 2 days ago, and I sent them both home yesterday. So they both went home the next day. So you typically go home faster. There's less pain. And you probably recover, and you get your catheter out maybe about a week earlier. So those kinds of things I think are an improvement. Blood loss is much better. The average transfusion rate, even though if you go to a conference and you ask anybody, they'll say, I can't remember the last time I transfused anybody. But the actual numbers, if you look at the Ontario data, the transfusion rates are about 5 to 7%. Of needing a blood transfusion. So it is very rare with robotic surgery. So I've been doing robotic surgery for 2 years, and I haven't transfused a single patient yet during that time. So transfusions are better. And bladder neck contracture rates. So the idea is that when you remove the prostate, you have to sew things back together again. And one of the challenges is leaking. But the other thing is actually developing scar tissue. And so a number of men actually have to suffer through small secondary procedures where they have to have scopes put in where we sort of stretch or we dilate that scar tissue. And it's enough of an incidence to be a nuisance for those men, at least in my experience over the years. And that's pretty rare with bladder neck contractures, with robotic surgery. In terms of the functional outcomes, again, it really speaks to the surgeon more than anything else. I tell my patients that I don't think there's any significant difference that I can credibly tell them with respect to improvement in urinary function and sexual function. I think they may recover to whatever they're going to recover faster, maybe in less time than it takes. But I think it really comes down to, it's still about the thought and the care behind the surgery and the experience behind the surgery. A lot of the robot data, I think, is a little bit contaminated, though, and I think we have an opportunity in Canada to do better and to actually hopefully provide and demonstrate some evidence as time goes on that it is better. 'Cause in my heart of hearts, I think it is going to, we are going to show it to be better. The big problem is really driven by what's happened stateside. I think about 80 to 85% of all prostatectomies in the US are now done robotically. There was a real run to it. That's what you did. And if you weren't in the robot business, your patient was going to go down the street because your competitor was offering a robot. So that's what drove it the last 10 years. If you look at the average number of radical prostatectomies done in the US by individual surgeons, I mean, it's a curve. It's a crazy curve. It's a curve like that one I showed with PSA. It's a flat line, and then it goes way, way up. So the average urologist does less than 10 radical prostatectomies a year, probably less than 5 a year in the US. You know, and a lot of those have access to robots. So any surgeon doing 3, 4, 5 cases a year, it doesn't matter what tools you put in his hand, or her hand, it's going to not have the same outcome as as somebody who does 100 a year, right? So, but if you give a good surgeon a better scalpel, you'll probably do better surgery. So that's intuitively the way I think about the whole robot question. And part of the reason why I wanted to be one of the earlier adopters of it was so that we could, drive it a little bit in terms of understanding how this technology might disseminate and where we can see the advantages to it. It's very expensive. Every program in Canada to date has been philanthropically driven. Government doesn't pay for it, and Cancer Care Ontario just pays for the standard rate, if you will, and hospitals will then top things up by the whatever the extra robot costs are. So I think to harness such a technology, you need to have it done probably in where you can share it, where you can do large numbers of patients, hopefully, and then diffuse the cost of that. But I do think in that environment where we only do it in Canada, wherever there's a robot, it's being done 100 times a year or 150 times a year. I think we have an opportunity to demonstrate that we're going to show different data than what's been shown so far. But it's going to take time, and but I think that's what's going to happen as time goes on. Yes, sir.